Assalamu alaikum, everyone. Good evening. Thank you for the lovely introduction. Um, I'm Safwan. Some of you may know me. I graduated my internship in 2023, and then in July of 2024 started a residency in general surgery here at Mayo Clinic in Rochester, Minnesota. It's a pleasure giving this talk. Um, a lot of you may be interns or slightly more junior medical students who are looking to apply to surgical electives at some point. And at the time when I was applying to surgical electives, there wasn't, I guess, much guidance, that was available for surgical electives. There was general, guidelines and advices available for, electives, and most of them were medicine electives. And I think it was a great initiative to have a talk that is more catered towards people applying for surgical electives because undoubtedly the experience is different from a medicine elective than it is on a surgical elective, where in the latter it's certainly more hardcore, it's more hands-on, and in general, people may be harder to please just because of, the expectations from a final year med student who's coming in to visit on the service. Um, I have a presentation ready that I can, go through, and of course, I welcome any questions as they come along. Um, th just and again, this is, based on the experience that I had and the pitfalls and mistakes that I made, and also, as a surgical resident, what I expect from a med student that's coming on the service, like what makes them stand out. So it's both from the perspective of a person who did electives and also from a person who sees people coming on for electives. So I think it should be pretty beneficial for y'all. Let's get started. So this is my presentation. It's very primitive, so it's very boring, but it's more about what I say, right? We're going to talk about things that you can do before you go on an elective, and then what you can do during and what you should do after. I'm sure um, at least one of you have at least one of these questions in your mind right now about surgical electives, and hopefully I'll be able to answer those. Let's start with before you go on a surgical elective, and I like to take a moment and talk about the specialties that are available to rotate in. And I think that's really important. If you are an intern right now, you're halfway through your internship, I think for the most part, you should have recognized what surgical specialty you would like to go into. Okay. Well, first off, you should have recognized whether you want to go into surgery or not. And if you've already recognized that, then you should know what specialty you would like to go into, because this is not the time to, you know, decide based on experience, that based on prospective experience. So you cannot, or you should aim not to apply for electives to try out that specialty. You should have already known by now that what specialty you would like to go into and apply for electives that will set you up for that specialty when it comes to an ERAS application. So these are the specialties that are available to rotate in the United States. And I think the reason you should really aim to apply for the specialty that you will be pursuing in residency is because the main aim of doing an elective is to get a letter of recommendation, and you're going to upload that letter of recommendation to your residency application. And if that letter is not coming from a surgeon that is in the specialty that you're applying for, it doesn't look good. Okay, it's not preferred. So just like if I'm applying for an internal medicine residency, then a letter from a general surgeon or an orthopedic surgeon, that is not going to be preferred. And the reason for that is these are two different experiences with two different, set of requirements. And people just like to see familiar names and familiar specialties in your residency application. So apply where you want to do or apply in a specialty that you want to do residency in. Okay. And even under surgical subspecialties, it becomes a little difficult because there's so many of them, right? And it's not like internal medicine where you can do an elective in cardiology or nephrology or gastroenterology or rheumatology or whatever the heck there is. And you can apply for a medicine residency because all the letters would come under internal medicine because all of those subspecialties have to do an internal medicine residency for 3 years and then go into fellowship. But for surgery, it's a little bit different. Some of the subspecialties, they have their own residencies. So for instance, vascular surgery has its own residency, orthopedic surgery has its own residency, OB-GYN, ENT, ophthalmology, plastics, neurosurgery, urology, they have their own residencies. And if you don't plan on going into that particular specialty for residency, then don't apply for an elective in that specialty if you want to be a general surgeon or if you want to go into a general surgery residency. And I'll talk a little bit about that as well a little bit later. So let me go over some of the subspecialties that are available. We have the big broad category of general surgery. I am a general surgery resident. I'm more well-versed in the subspecialties that are available there. So I'll talk a little bit more about that. But I can, briefly go over some of the other specialties that are available to apply to. In general surgery, we have, something called core general surgery. This is, surgeons who take care of hernias, of gallbladders, appendix, bowel obstructions and all that. Very core general surgery. And you can certainly go and apply for that elective because it's very operative and you get the core, the bread and butter general surgery experience. There's surgical oncology. These are, this is the specialty that takes care of tumors and cancers. There's breast, there's hepatobiliary, which takes care of liver and pancreas and the biliary system. A lot of the times this overlaps with surgical oncology in some institutions and really takes care of like liver, biliary, and pancreatic cancers. They perform procedures like Whipples and hepatectomies and all that kind of stuff. Transplant is certainly a subspecialty after gen surg. Trauma acute care. This in some institutions can overlap with the core general surgery that I talked about in the beginning. And this, talking specifically about trauma, I would, advise caution there because depending on the institute that you go in for an elective, trauma may not be an operative rotation. You may not get to do a lot of operative trauma just because of the kind of trauma that comes to an institution. And the way that things are set up in the US, there are institutions that get a lot of operative trauma, and there are those that don't. And then this, different institutions get different types of trauma. So, for instance, where I train, we don't get a lot of operative trauma. We're in the middle of nowhere. It's a pretty safe area, so we don't have a lot of penetrating trauma that comes in. It's mostly like just old people who have fallen down on the floor and broken some bones. So orthopedics take care of that stuff, but we don't operate a lot on the type of trauma that comes in. So if you are interested in getting operative experience in the elective, then and trauma is something that you've found, just make sure that the institution you're going to gets a lot of operative trauma. Okay. But trauma surgery is certainly a specialty that you pursue after a gen surg residency. So if you get a letter out of trauma surgery, then that's completely acceptable and welcome. So certainly look at the institute you're going into, and if you plan on doing a lot of surgeries or learning a lot of surgeries, then trauma may not be the way to go if you go to a place where it doesn't get a lot of operative trauma. Surgical ICU is a completely non-operative rotation. So if you do a SICU rotation or surgical ICU, you will not be performing any surgery. This is basically like an ICU medicine rotation that just takes care of like 6 surgical patients. So but it is a subspecialty that comes after a gen surg residency. So critical care surgeons are people who take care of sick patients in the ICU, and they are surgeons. So you will get a letter from a surgeon, but you will not get any operative experience during that month. Hernia surgery sometimes can also overlap with core general surgery, such specialties, but there are institutions like my own where hernia is a separate department. Endocrine surgery takes care of like thyroids, parathyroids, adrenals, and neuroendocrine tumors. Pediatric surgery certainly do that. It's a fellowship after gen surg. Bariatric surgery is certainly one that you can go to and apply for. MIS is minimally invasive surgery. That is also a good candidate for an elective. A lot of institutions have MIS, and that basically means bariatric surgery and hernia surgery. So that's what minimally invasive means. But it is a fellowship after DenSert, and certainly something that you can pursue. Colorectal is also a specialty that you can apply for, an elective. Now, the last three, vascular, plastics, and cardiothoracic. In the past, I'm not saying recent past, but in the past, vascular surgery, plastic, and cardiothoracic surgery were fellowships after a gen surg residency. So you would do 5 years of gen surg, and then you would go to vascular and do like a fellowship of 2 to 3 years. Plastics is, I don't know how many years. Cardiothoracic is like 4 years or so. That has changed a little bit, and it continues to change in the sense that these vascular, plastics, cardiothoracic, they have their own integrated residencies. So vascular is a 5-year program, I think. Plastics is, I think, a 5-year program. Cardiothoracic, I think, is a 5 to 6 year program. So they have their own residencies. So if you want to go into general surgery residency, then it is probably better that you don't apply for these electives. That being said, this is just based off an interaction that I had with one program director, where I had a cardiothoracic letter, and she told me, why do you have a cardiothoracic letter if you want to go to gen surg? And the reason for that is because cardiothoracic surgeons a lot of the times are not general surgeons. But there are still a lot of people who still do vascular, plastic, cardiothoracic fellowships after gen surg. So it's not, it's not something that's unheard of. Okay, so if you can't find any of the other electives, if you plan on doing a gen surg residency and you're finding vascular, plastic, cardiothoracic, go for it. It's certainly something that you can do, but prioritize some of the other subspecialties before you apply for vascular, plastics, or cardiothoracic. Especially also, if you're interested in these subspecialties and plan to pursue it after a gen surg residency, then go for it. Okay. All right. So those are general surgery and its subspecialties. So if you were planning to do a gen surg residency, those would be electives to apply for. And then there's, the cardiothoracic, plastics, and vascular that I talked about. There's neurosurgery. It's a completely different world. Okay. It's a 7-year residency. You don't have to do a gen surg residency before. It's a completely different world with a completely different set of requirements. So if you don't want to do neurosurgery, do not do an elective in that. Don't be like, and this was me, let me do a month of neurosurgery so I can try it out and make sure this is not the specialty that I want. And this was literally the last month of my internship. And I would say that I might have wasted that month, including some money and time doing a neurosurgery elective when I did not want to pursue neurosurgery. Okay. So that's why I said at the beginning, you should have laid out a pathway for yourself right now if you are an intern as to what subspecialty in surgery you want to go into. And neurosurgery especially, it's certainly a very competitive residency to get into, and requires a lot of hard work that goes in, long before internship. So people who are into neurosurgery, they've been practicing to get into it a long time before even their internship started. So those are the people that should go do neurosurgery electives. But if you want to do urology, if you want to do plastics, don't do neurosurgery electives. It's a waste of time. It's a waste of money. Don't try out specialties in your electives because you only have a certain number of electives that you can do. You only have a certain period, limited time, limited money, limited resources, and so use them to the best advantage. Okay, urology, it's a completely different world. I think it's a 5-year residency by itself. You don't have to do a gen surg residency. So if you want to do urology, don't do a general surgery elective. Just for the sake of doing a surgical elective because you can't find any other thing. So aim for finding urology electives. Orthopedics, bones, have nothing to do with gallbladders and appendix and the brain, So although there is some overlap between neurosurgeons, orthopedics in terms of spine, if you don't want to do, orthopedics, then don't do an elective in orthopedics just because you want to do a surgical elective. It's a completely different realm, different world, different people. And a letter from an orthopedic surgeon will not be welcome in a gen surg residency application. OBGYN, ENT ophthalmology, if you don't want to do these subspecialties, then don't do electives in them. I think that's my advice. And this is the reason that I have this slide here, because I made that mistake of doing an elective, or actually two, where while I did get letters from them, I did not, honestly didn't even use those letters in my application because my application was to a general surgery residency. So if, just set yourself up better from the beginning. Things are a little bit more different now and more easy compared to when I was doing my electives. There's a lot of more resources available. There's a lot more options available. How do I maximize the number of rotations that are available to me? You go to those, you go to the VSLO and apply through there. Go to individual program sites and apply through there as well. If it applies to that particular program. I know, for instance, Cleveland Clinic have their own website to apply through, and emails. If you can't find a program elective in either VSLO or there's no application on the program site, just email them and really just kind of spam them if need be. Send mass emails to multiple programs asking for opportunities to rotate. Where do you find their email addresses and who to send to? You're going to send the email to the program director and the program coordinator, and you can have a certain template of email that you send to pretty much everyone. Okay, follow up on these emails as well, because a lot of times you don't get replies. So I must have sent out 100 to 300 emails, and most of them were non-replies, and some of them were negative replies, and I did get a few positive replies actually. So they're definitely worth your time, kind of sitting down an hour or two a day and just sending out those emails to get the maximum opportunities. Things are better now, because at the time when I was doing my electives, it was still kind of recovering from COVID. So you should be able to have more opportunities. And just a quick Google search, X surgery elective at X institute, you should be able to find that program's website. You should be able to find their email addresses to send this to. If you can't, then go to Residency Explorer, and you can search for that particular program, or you can have a list of programs filtered by the subspecialty that you want, and then if you click on that program, you will have the email of the program coordinator and the program director. The program director is the person responsible for the program. The program coordinator is not an MD, it's not an MBBS. It's a person who's just an administrative person who takes care of emails and stuff, and will be a good person to contact when it comes to asking for opportunities to rotate. In terms of costs, I have that thing on this slide because a lot of the like every time you rotate at a place, it's going to be probably for 4 weeks, and it's going to cost. Okay, there's going to be cost of travel, there's going to be cost of food and living. There's going to be also program costs. Some of the programs, they take fees for you rotating at their institute. If you're really passionate about that specialty, if you feel like that is a very good opportunity, and you are held by the fact that it costs like $2,000 to rotate at this place, do not hold back. I would say it's a good investment to go ahead and apply and pay that money, because letters out of those places would really take you a long way. So don't hold back just because, of the costs, because it is an investment. You're nearly there. You paid 100,000 reals every year for the past 5 to 6 years. A couple of thousand extra, it's not going to hurt. Okay, so think of it as an investment for your future and go for it. Unless you find an option that is better and it's free, it's less costly, then obviously go for that. And there's a lot of reimbursement programs at the university where you can get your money back. So don't worry about the costs. I know it's easy to come from someone who's already done it, but looking back, I did miss out on some opportunities which were paid, and I did not apply to them because it was costly. But I could have gotten it, and could have gotten letters. So I'll tell you, I'll say this to you guys, okay? So you can do better. So this is the template of the email that I used to send out to everybody. It would be query regarding clinical rotation for international visiting medical student. Gosh, this is a long time ago, but it would be a standard email. I would tell them where I'm from. Tell them where I'm studying at. And for some reason, I was told to add this line to my emails recognized by the Medical Board of California. I have no idea why, but I just added it to my emails. Maybe it sounded more familiar to them. Personally, never did a rotation in California, but whatever. And then you would write the specialties that you're interested in, and then you would write the months that you are interested in rotating during. Additionally, you should add your step 1 score, or pass or whatever. Now I did it with a score. And this I'll stop here for a second and just kind of remind you all that you should all have done your step one if you're an intern applying for a US residency and looking to do electives. If you have not, that is your priority right now. And then a lot of the electives also require like an English proficiency exam, and so I included the score of my TOEFL, because that's an English proficiency exam that I had done at the time. And you just wait. A lot of the people are not going to reply, and just email them back, reply to this email, and reach out and be like, what's up? You haven't replied, and waiting to hear back. And some of them might reply after that. So, just do all the efforts that you can, especially if you're in a pickle and you don't have a lot of options and you're running out of time. Okay. So yeah, feel free to just copy this email, obviously change my name, change all this stuff, and you should be able to find something. Okay. All right. So now I've talked about what to do before, in terms of application, and what specialties to apply to it. And I think that's really important. If you've already done it, if you've already applied to something and kind of goes against some of the stuff that I've been talking about, do not worry. Just go for the elective, do your best, and it will still be a learning opportunity. Okay. And understand that the goal of these electives, yes, is learning, but you're not going to learn how to do surgery, right? The goal of this elective is to learn and adapt to the US healthcare system. And the ultimate goal is to get a letter of recommendation. And yes, it sounds weird, it sounds stupid that you're paying a whole bunch of money to get this letter, but it's required for your US application. And the worst US letter is better than the best Saudi letter. So might as well just aim for the letter when you go on a rotation. Okay. And I always say this, the rotation is an audition. All right. So you're going to showcase yourself, you're going to show off. But at the same time, you have the objective of learning. But aim for that letter. I think that's kind of the aim of this rotation. If you go to a rotation, if you don't get a letter, then to be honest, you wasted your time and money. Because yes, you've learned a lot, but it's not going to add to anything. It's not going to amount to anything. So yeah, we've already talked about all that stuff. And now I want to talk a little bit about what happens once you get to the rotation and you're in a US healthcare system, which is kind of different from the Saudi healthcare system. It's going to take a while to adapt, but if you anticipate the changes, it'll take less time to adapt, and you'll be quicker to kind of catch on things. You only have 4 weeks at an institute, right? So if you take too long to adapt, you're done with the rotation. You haven't impressed anyone, and you're going to go with either poor letter or no letter. Okay. So anticipate the needs and anticipate the need for change, and just kind of look forward to change and embrace it. Okay. However cheeky that sounds. So the US healthcare, the insurance thing is a little bit different than Saudi. But the things that you should really watch out for is, number one, patients are more involved in their care in the US than they're in Saudi. And this is a difference that I've noticed. Patients in Saudi, they'll agree to whatever you say, but in patients in the US, they will ask a lot of questions, and you should prepare to answer those questions. And if you don't have to answer those questions, it's very, very reasonable to say that you don't, and you will touch back after talking to somebody else. The generic names of medications, Panadol, Tylenol, all that kind of stuff. It'll take a while to get used to it, but I think just know the generic names of common medications before you go to a place, because no one says acetaminophen. People say Tylenol here. Electronic medical record. Okay, people in the US either use Citrix or they use Epic. And if you've rotated at some of the hospitals in Saudi, you should have had some exposure to these electronic medical records. Some of the places might use something else. I'm not aware of that, but look up the electronic medical records that the place uses beforehand. And a lot of the programs, before you go there, they have like an onboarding course that you have to do, and they'll go over some of the key details of the electronic health record that you need to know, because you can't spend too much time getting used to a medical record while you're there to learn and show off your skills and knowledge, because that's a very trivial thing, and it should be something that you catch on to very quickly, because it is important in your learning, and it's important to know how to use because you'll be using it every single day. Otherwise, it's not much different, So apart from the culture, apart from the type of people, it's not much different than Saudi. So, you know, don't be shy, don't hold back, and just be, keep smiling and just, don't let the differences get the best of you and, you know, hold you back from performing at your best. I guess one more thing I forget is here in the US, there are people who didn't do med school. They're called APPAs, or nurse practitioners and physician assistants, and these are people who haven't done med school, but they are very much involved in patient care, just like doctors are. So they're able to prescribe. They're able to they come, they see patients by themselves independently, and they write progress notes and they prescribe medications. They're not doctors, but they are still very important people that are involved in patient care and part of the healthcare team. And so we'll be working alongside them, and you should appreciate their experience and you should appreciate their advices, and because you will learn a lot from them. Those I believe they're not present in Saudi, not just yet. Okay. So I guess those are some of the differences that you can expect when you go to the US. It's important to know what is expected of you as a med student who's coming on a surgical service when you go to an institute. And I combined all the things that you need to know into three main categories: knowledge, skills, and communication professionalism. So we'll discuss each of them and their relevance to a surgical rotation. We'll start off with knowledge. These are the things that you know. These are the things that you've learned in the past 5 to 6 years. All the lectures that you've done in the past 5 to 6 years that come under knowledge. And if you're going to a surgical rotation, do not go without knowing your anatomy. Okay, so please revise your anatomy. And I'm not saying revise the whole human anatomy. If you're going for endocrine surgery, you should know the anatomy of the thyroid, parathyroid, the neck, and the adrenals, because you're going to be operating a lot on those kind of people. So you should know your anatomy, all right? And not like superficial anatomy, know the details. If you are going for a neurosurgical rotation, you should know all the anatomy of the brain, the spinal cord, the skull base, the vertebral column, et cetera, et cetera. If you are going for a hernia rotation, you should know the anatomy of the groin. You should know the anatomy of the abdominal wall. If you don't, this is something that is very basic and 100% expected of a med student. So if you don't know this, then you're certainly doing something wrong, and you will not impress people. Also know the physiology. Some of the rotations physiology is really important to know as well. So just revise anatomy and physiology, at least that is relevant to the rotation that you're doing. Okay, because that way, not only you'll optimize your learning, but also you'll impress a lot of people by knowing stuff. Know the common surgical disorders of the rotation. If you are going for, let's say, if you're going for a core general surgery rotation, no cholecystitis, no appendicitis, no small bowel obstruction, no large, know about like volvulus, know about hernias, know their pathophysiology, their signs and symptoms, differential diagnoses, diagnostics, imaging, lab, special workup, biopsy results, and when to perform surgery, when not to perform surgery. And I think those are things that you should know of the, at least of relevant to the rotation that you're doing. Okay, I don't expect you to know about thyroids and parathyroids if you're doing a neurosurgical rotation or orthopedics rotation. So that is something that you certainly have to read up on before you go into a rotation. Next up is common surgical procedures. A lot of surgery is, while it's a very fun special, surgery is very fun, and you're really hands-on, but a lot of times it's a lot of repetition of the same kind of procedures. So know those common surgical procedures. So if you're going for let's say a hernia rotation, so you should know how to do different kinds of hernia repairs. There's TAPP, there's TEP, there is open repairs, there's laparoscopic, there's robotic. If you're going for let's say if you're going for a bariatric surgery rotation, you should know how to do, you should know the basic steps. I'm not saying the details, the basic steps, the basic anatomy of a Roux-en-Y gastric bypass, or a gastric sleeve, or a duodenal switch. If you're going for some of the OB-GYN rotations, you should know the common procedures that they do in that specialty. So know the basic steps of the procedure, so that you're able to describe it into like 6 to 10 steps. So it's very superficial. And the pre and post operative management of those procedures, and also know the complications of those procedures. And you can learn all this. You can go back to your lectures that you had. I think Alfaisal does a great job at teaching in terms of in a didactic manner some of these things that we've talked about. And so you can just go back to your lectures. You can go to Up to Date. Netter's Anatomy, I think, is really good. So just know your stuff before you go into a rotation. The reason I say this is twofold. The first is people are going to ask you questions. You're attending, your consultant will ask you questions. And if you don't have the answer consistently, or you're answering wrong consistently, then it shows that you're not prepared. Okay. And the second reason for it, knowing your stuff is, while someone may not ask you questions, you can ask them questions based on the stuff that you know. And I think that'll really impress people as well, is when you are involved and you are showcasing your knowledge by asking questions or, by identifying stuff. I think that would really impress people. So first, knowledge. All right. Next up, we've got skills. So that's how you apply your knowledge. You should know how to do a basic H&P, a basic history and physical exam of a surgical patient. So go back to all the professional skills sessions, all the OSCEs that you've done if you're an intern or fourth or fifth year, and know how to do a basic history and physical exam, be systematic, learn how to be systematic, learn how to be focused as well, right? So in surgery, we don't have a lot of time on our hands, and we can't sit with a patient for an hour and ask about, what genetic condition their great-great-great-grandmother had. So try to be focused to the presenting complaint. And I think also, I really think that Alfaisal does a great job at teaching its students how to do that in fourth and fifth year. So just kind of go back and revise all that stuff. Okay, that is relevant to the rotation. You should learn how to interpret basic diagnostic stuff, labs. You should know how to interpret a CBC, a BMP, which includes electrolytes and creatinine and BUN. You should know how to interpret an LFT. You should know how to interpret a urinalysis, because this is just basic. So this is stuff that you've been learning since like third year at the very least, right? And these are things that you can pick up and ask questions related to. Why is this patient's white count high? Why is this patient's hemoglobin low? What can we do about it? And if you bring these points up, people will know that you are not just reporting information, you're not just telling them that the patient's hemoglobin is low. You are coming up with plans as to what to do with that information. I think that transition really showcases that a med student who's coming on the service is really knowledgeable and it's really introspective. Okay. Imaging. All right. You should know how to do it, how to interpret a chest x-ray. And I've written it 3 times because it probably is one of the most common imaging modalities that you see on any surgical service, chest x-rays, right? You should know how to read a chest x-ray. Abdominal x-rays, CT scans will take some time to get used to, but once you see enough scans, you'll be able to pick stuff up, and try to sit down with a resident or a senior person and just go through all of these and talk about the pertinent findings, the important positives and negatives, and you'll pick up on the common things. You don't have to read a chest x-ray, CT, abdominal x-ray as a surgical, a med student is coming on a surgery rotation, because there's going to be a report, a radiologist doing that for you. But you won't learn that way. So if you see a chest x-ray, if you see a CT abdomen pelvis, or if you see an MRI, before you read the report from the radiologist, try to scroll through the images yourself, and then try to compare your impression with the radiologist's impression. Next up in skills is being able to propose a plan, and that's what I said earlier. So being able to know what to do with information is really important as well, and that'll come with time. That'll come with repetition. But if you're able to tell me what to do with a low urine output, I would be very impressed with that. Okay, so don't just be a reporter, okay? Because there's other people who can just report information, right? It's just like, why are you reporting this information? Why are you telling me this patient's ALT, AST is high? Also learn and develop an ability to know what to do with that information, coming up with a plan to do with that information. Next up is basic procedural skills. So you should know how to drop an NG tube, venipuncture, although you will probably want to do venipunctures nursing staff does that usually. You should know how to place a Foley. You should be placing Foleys in the OR as a med student, and you should be the one at the forefront of putting in Foleys. You should always offer to put one in, because it's a basic, it's a basic procedural skills. You've all learned how to do this in year 2, I think. So, you should be able to do this by yourself. And then we'll talk about some of the basic surgical skills that you should know before you go on a surgical rotation. First skill, you should know how to consent a patient. It's kind of, the process differs institute by institute, but in general, a consent requires you to talk about risks of the procedure, benefits of the procedure, alternatives to the procedure. You should be talking about, the procedure itself, basic, steps of the procedure, answer any questions that the patient has. When it comes to risks of the procedure, you should always talk about, bleeding, infection, and damage to surrounding structures. Don't just talk about the risks, talk about how you're going to mitigate them for the patient. You're not going to scare the patient out an hour before surgery, right? So you talk about, for bleeding, we always have blood products available. For infection, we get preoperative antibiotics. For damage to surrounding structure, you reassure the patient that an experienced person is going to cut you open, so you're going to be fine. And you can always quote data of complications. So for instance, if you were consenting a patient for a cholecystectomy, you can always tell the patient there's a risk of injury to your common bile duct, but it's less than 1%. So they're going to be reassured. Okay. So you should know how to consent a patient. And while this is not something that med students usually do, you should always offer to do it for learning experience, but also to, kind of showcase that you're being proactive. You should learn how to scrub in, which involves, scrubbing and then sterile gowning and sterile gloving. When it comes to sterile gowning and gloving, you can do it by yourself, or you can have a nurse do it for you, or a scrub technician. Probably go by whatever the scrub technician is more comfortable with, because a lot of the times med students break sterile fields, and just to be on the safer side, the nurse would gown you, the nurse would glove you. So whatever they're more comfortable with, do that. And if you yourself are not comfortable with self gowning or self gloving, you just let them know you're not expected to self gown and glove at a med student stage. And so it's completely reasonable for you to say that you don't know, and have someone else do it for you. Next up, you should learn how to prep and drape. This is basically, when you kind of prep the patient's skin before surgery. And again, this is not something that you as a med student would probably do, but still offer to do it. It's a pretty simple task. And, after seeing a few people do it, you should be able to do it by yourself. It's not that hard. Draping is a little hard, so we just let the scrub technician do that for us. And sometimes, it's their preference that they drape by themselves because they have a certain way of doing things. You should learn how to make an incision. It's not just taking a knife and cutting the skin open. It is, your knife or your scalpel has to be perpendicular to the skin, so you don't skive, because if you skive, that sets the patient up for poor wound healing. So learn how to make a proper incision. You can practice with taking scalpel from other suture kits and just practicing on that silicone pad, right? And again, as a med student, you probably won't be asked to make incisions, because we have residents who do that or attendings who do that. But, you should always offer, towards the latter half of the rotation, you might be like, I would like to make the incision this time. And then, sometimes they might let you. It tells them that you're being proactive. And the worst that can happen is, they say no. Now, next up is suturing. This is very important. This is something that is expected of you. You should learn how to do these kind of sutures. You should learn how to do a simple interrupted, deep dermal, running subcuticular, figure of 8, and vertical horizontal matrices. And you can find videos online on how to do this. I would say running subcuticular is I would say one of the most important ones that you should know how to do, because that is basically how we close skin for the most part, especially the longer incisions. And I think this is something that we always let the med students do, because we don't. This is one of the simpler parts of the procedure, and we're very, very comfortable with letting a good, experienced med students do that. Next up is knot tying. You should learn how to tie knots single and two-handed. You can find videos online of doing this. So this is not just, just tying a knot like you tie your, I don't know, any other knot. This is a short surgical knot, so know how to do that specifically. You should learn how to staple and remove staples. You should know how to remove surgical drains. A lot of times we leave surgical drains in people, and there's a certain way to remove them. Just have a resident show it to you first, and then you can do the next ones during your time on the service. You should know how to do dressing changes, and this is also really important. So when you go on rounds as a med student, you should have all the dressing equipment with you. So have the gauzes, have the Kerlix, have saline flushes with you, because that'll really show that you are, looking out for the team, and you are being proactive in changing the dressing, because this is something that you should be able to do. Okay. Wound vacs are basically suction dressings that we have on. It promotes wound healing. You should learn how to manage that. And again, if you haven't seen it, that's fine. Once you see it, it's pretty easy to learn how to manage it. And then just know the basic surgical instruments. You don't have to know the names of all of them. And, we don't use all of them in all the specialties. So just, after a couple of days in the OR, on your rotation, you'll be able to pick up what are the instruments that your consultant specifically likes to use. So I think if you're good with these, some of the basic surgical skills as a med student, you will not only be comfortable, but you'll actually stand out. Okay. All right. Next up is communication and professionalism. This is very important, very cliche, but very important. So dress well, follow the dress code. If they tell you can't wear scrubs without a lab coat on, or if you can't wear scrubs back home, then don't do that, because it leaves a bad impression. Communicate effectively. Always, whenever you go somewhere, introduce yourself, introduce your role, and always offer to help. This is where some of the communication tools that we learned in professional skills in the first 3 years come into place. And at the time we had thought that they're completely useless, and why are they making us do all this boring stuff? But it's it comes in handy after. So like ISBAR and all that stuff. So in the US, it's norm. It's the norm to call residents and fellows, even if you're a med student, by their first name. But attendings and consultants, of course, have to be called by doctor, whatever. When you're in surgery, there's a lot of curse words going around compared to some of the other specialties. But you as a med student who's trying to audition for, for getting a good letter, don't use any of the curse words. Okay. Keep smiling, as I said, and always, always, always be open to criticism, be open to feedback, be open to change. Don't be stubborn. You have, I'm not saying that a med student on the service is like useless and something that people, should disregard, because they're there for learning. But your stubbornness will not, change patient management at all. So it doesn't matter whether you like a certain thing or not. Be open to understanding why people want you to change, and don't be stubborn about it. Okay. Because I've had med students on the service who are very stubborn to change, but it makes them stand out in a very, very negative way. So don't be that. And this, I guess, applies to really any rotation you're doing, maybe except for the curse words. All right. So those are the expectations that a med student, those are the expectations of a med student on a surgical rotation. Now, what should you expect as a med student out of a surgical rotation? What does it give you back? Is number one, exposure to the operating room. And, that's kind of obvious, right? If you're doing a surgical rotation, you're going to be in the operating room, but it's not as simple as that, really. It's not as simple as that. The operating room is a very different kind of environment. It's a very high-paced environment where everyone needs to get things done to move the schedule going. You can't slack off. You can't lag behind. So this is something, this is a place where, it's kind of all hands on deck. You have to be around to help people. It's very cold. It's a different kind of place, right? So exposure to the operating room just by being in the operating room is something that you should expect out of a surgical rotation. You're not going to be practicing on silicone pads anymore. You're going to be, suturing. You're going to be cutting open real people, real patients, right? So that is something that is, I guess, is more of a surreal experience if we haven't done it already. You're going to be doing histories and physicals on real patients. So you should always, be at the forefront of offering to do that, because otherwise you're just doing it on SPs as a med student, as an intern, right? So maybe not as an intern, but always, this is something that that comes out of a surgical rotation for a med student. And then, you see residents around you, you get a glimpse of what surgical residency is like. And maybe, that makes you change your mind, perhaps, because it's, a surgical residency is certainly very different than some of the other specialties. You're there for more hours. It's more hardcore than a medicine specialty, for instance, right? So you get a glimpse of what residency would look like as a surgical resident, and what are the tasks and goals of a surgical resident as opposed to some of the other subspecialties. And then, of course, the main goal here is to get a letter of recommendation. However bad that might sound, because you're there to learn all the things that we've just talked about, and practice all the things that we've just talked about. But at the end of the day, if you don't get a letter at a clinical rotation that you paid for, that you've traveled thousands of miles for, then what did you get out of that rotation? It doesn't go towards your application. So while it certainly was a good, enriching, enlightening learning experience, it doesn't add much to your application, apart from the fact that you can write this as an experience, which I guess is something. But the letters go a longer way. How can I prepare in anticipation of my surgical rotation? This is all that we've talked about so far. All right, so knowledge, skills, and learning how to be professional and learning how to communicate effectively. All right, so just to kind of give you an example of what it might look like as a med student on a surgical service, I thought I'll give you an example. And this will kind of, complete the picture of all that is expected of you and all that you'll be doing in a more practical manner. So around and surgery will start early, right? So you get there at 4:45, 5 a.m. in the morning, and you should be there before everyone else. All right. So these yellow boxes that you're going to see in the next couple of slides is very important to look at, because these are the things that will make you stand out. Okay. As opposed to just, be one of the med students that came to the service. They're going to know you by name if you be there before everyone else. So get to the workroom is very standard for, and this is not specific to institute. Wherever you go, you're going to have a list of patients, all right, that you're going to print before rounds. So you should always offer to print that list. And then you're going to get some numbers, and then you might pre-round on patients. So I'm going to talk about what does numbers mean, and what does pre-rounds entail. All right, getting numbers. So this is what a list might look like on a surgical rotation, right? So you have the name of the patient, you have the room that they're in, you have their primary problem and what surgery they had, and then you had some of the recent events that they had. And then you might have a list of, however many patients, depending on the specialty you're rotating in. Might have 25, you might have 4. Okay, so just print that list, and always offer to print out the list, as I said earlier. And then you're going to get numbers. So what is getting numbers? So these are the numbers that you're going to be getting every single morning on the patients that are admitted to the hospital. Getting numbers. So number one is the vital signs. All right. So the temperature, heart rate, blood pressure, maybe respiratory rate, and SpO2. Temperature. Record the maximum or the minimum temperature that the patient had if they're afebrile or if they are hypothermic. Okay. If they're afebrile, if their temperature was within normal limits, then you can always just say afebrile. Heart rate, it should not be a single value. It has to be a range. Okay. Why is that? The last time you got numbers on this patient would have been 24 hours ago, yesterday morning at 5 a.m., right? And so from yesterday morning at 5 a.m. until 5 a.m. today, what has the patient heart rate ranged from to from? Okay. From and to. So the patient's heart rate, the minimum heart rate the patient had was like 92, and then the highest was like 105. So the patient's heart rate range is 90s to 100 or 90s to hundreds, or you can do like 92 to 105. And so this is what the patient's heart rate range. So it cannot be a single value, because that doesn't tell me anything, right? It has to be a range. Same goes for blood pressure. Same goes for respiratory rate. And then when it comes to SpO2 or oxygen saturation, this is going to be the minimum oxygen saturation that the patient had throughout the past 24 hours. So if the patient had, let's say the patient has 89, 95, 98, 100% oxygen saturation recorded or charted in the electronic medical record, then you're going to say that the patient had a minimum of, or a patient had greater than 89% oxygen saturation over the past 24 hours. And then you also have to say whether this was on room air or whether this was on nasal cannula, and how many liters of nasal cannula. Was it on 1 liters of oxygen, 2 liters of oxygen? Was this on a CPAP? Was this patient on a ventilator? So I'll get all the ventilator numbers as well. So that includes things like PEEP, FiO2, maybe tidal volume. And again, those things will come with practice. If you don't understand that now, that's completely fine. But that'll come with repetition. But if you are going to a rotation where you expect patients to be in the ICU, know a little bit about the ventilator. Okay. Next up, you get the I's and O's, inputs and outputs. This is important for fluid balance for the patients. So input, this all will be recorded in the chart of the patient. So you just have to go to the right place and you'll find how much the patient had to drink, how much IV fluids the patient got, urine output of the patient, and if the patient had any bowel movements. And then you would kind of record the net for the day and the net since admin. So for instance, for this patient, it looks like 1,500 minus 700. So this patient is about 800 cc's positive today. Okay. So those are the I's and O's, and you really just have to just kind of write them down on the list that you printed, and then you're going to get the labs, and these are the fishbone diagrams that you should remember for getting the labs. You don't write NA:136. No, you just have to draw this fishbone out and just write the numbers in the appropriate places, and people will know what that means. And so be familiar with these fishbone diagrams. Okay. Now, in terms of getting numbers, there's different way that different people like to do it. So just ask the residents on the service how they like their numbers to look like, and then it's not just about getting these numbers, right? So while you're getting these numbers, as you're writing them down on the list that you printed, identify the abnormalities, identify the abnormal heart rates. If the patient was tachy or bradycardic, the patient was hypotensive or hypertensive, the patient wasn't saturating well. Identify this as you go along. Patients, potassium was 3.4 or 3, or was it normal? The patient's hemoglobin was low. Patient's white count was high. Patient urine output was low. As you identify these derangements, they're going to help a lot. In the next part is, when you round on the patients and you report to your seniors what happened in the last 24 hours. And as you're identifying these derangements and abnormalities and these numbers, learn what to do with them, right? As I said earlier, don't be a reporter, be a person who knows what to do with information, right? So the patient's, urine output is low. In your mind, things should be going on. What does that mean for me? If the patient's urine output is low, maybe, they're not getting enough fluids, or maybe they have heart failure and they have low effective circulating volume and they have like a pre-renal azotemia, maybe, or maybe it just wasn't charted. So, talk to nursing staff, did this patient actually not put out any urine over the past 24 hours, And so this should be going on in your mind. So you can come up with plans. You can be like, oh, okay, this patient's urine output was low. The patient's creatinine was high. I want to give this patient some fluids versus I want to diurese this patient with some furosemide to test them if they're fluid overloaded with just low effective circulating volume. If the patient has not had any bowel movements for the past 3 days, okay, you should recognize that and be like, okay, I think we should probably give this patient's like some bowel regimen, maybe some senna, some polyethylene glycol. Maybe we should get an abdominal film and see what it looks like. Maybe this patient has an ileus, right? So those are the things that you should pick up on as you're getting these numbers. Okay, you're not just writing them down; you're also processing them as you go along. And one thing I forgot to mention here is always trend the numbers. Okay, if the patient has been here for some time, also record what the patient's numbers were yesterday, and we usually do that by writing it in a bracket just next to today's values. And you don't do that with everything. You do that with usually the labs and usually the urine output. You trend this over the past few days, just so we know how the patient is either progressing in the right or the wrong direction. So yeah, this is how you get numbers, and you just put these numbers on the list that you printed in this manner, and then you just copy it for the whole team. And again, it differs institute to institute. So just ask the residents on the service how they like their things to be done. All right. Next up, you pre-round on the patients. Now, what does that mean? Why is it called pre-round? So round officially is something that you do with the consultant or attending. And pre-round is something that you just do by yourself or amongst the residents. And this is just going to be a quick visit to the patient's room and to do a quick H&P and ask about overnight events. You're not going to stand at 5 a.m. in the patient's room and ask if they're, ask about their family or smoking history. Okay. If it's not relevant to today's plan. So it's going to be a quick visit and ask about what happened since yesterday, what happened overnight, what has changed, what has gotten better, what has gotten worse. And, as a standard, I always like to ask about pain, nausea and vomiting, if they're passing gas versus if they're burping or belching, if they have any shortness of breath, if they have any chest pain. All right. In addition to that, you would ask about the things that are relevant to the type of surgery that the patient has. So if the patient had a thyroidectomy, some of the questions to ask would be, are you having any neck soreness? Are you having any difficulty taking deep breaths? Are you having any voice hoarseness? Uh, you might have them do a couple of voice tests just to make sure their RLN or recurrent laryngeal nerve is intact, right? And so it's just, in addition to these couple things, it's also the things that you ask for have to be relevant to the rotation that you're on and the type of surgery that the patient had. And of course, do a quick targeted physical as well. It's always good to, this is one of the things that I've learned as a resident here is, always listen to the patient's lungs, regardless of the type of surgery they had. It's just because patients were in the hospital and they're bedridden for some time, their lungs are atelectatic, and it's basically a setup for pneumonia to happen. So always listen to the patient's lung and see if they're having good air entry bilaterally. So my point being, always carry a stethoscope with you, even as a surgical person. So some of the things that will make you stand out: talk with the nursing staff, overnight nursing staff, to see how the stuff went overnight. And then the way that, you kind of be more comprehensive and be more, I guess, invested in a single patient is you just follow that patient throughout your time on the service. So if there's the patient that you are interested in, ask the residents if you can follow them, as in you can write their progress notes, you can just follow them, you can follow their plans and their progression throughout their hospital stay, during your time in the service. And if there are a lot of patients, they can offer to help and, ask to follow 1 to 2 patients. And this will really, give you a glimpse of what it's like to manage floor patients, do stuff outside of the OR, because as a surgeon, you're not just in the OR, you have patients in the clinic, you have patients on the floor in the ward, that you also have to manage, right? So you should learn how to do that. And in order to do that, you can closely follow 1 or 2 patients, and, do all the stuff related to them. You might need help putting in orders, so just have someone else do that for you. Okay. Now about 6 to 7 a.m. This is when you can, you may around with your attendings and senior residents, ask the residents how the particular attending likes their presentations to be presented. And then you would do a presentation based on the numbers that you've gotten, based on the pre-round that you did. And we'll talk about SOAP presentations in a second, and then you will write your progress notes, and then you'll head to the OR. Again, the timing is just, it may not be how it happens at the place where you go to, but this is what it might look like, okay? So presentations, I know you guys have all been working on it over the past few years, even maybe during the intern year. Starts with a one-liner on the patient, the type of surgery they had, subjective, S is for subjective, overnight events, so really symptoms that happened, and objectives, always for objective. This is when you talk about the patient's vital signs, I's and O's, labs, and imaging. And then assessment and plan is, assessment is what's happening and plan is what's next, okay? And this will just come with time. This will come with practice on how to present patients with SOAP presentation, using the SOAP format. One thing I would say is you can use words like within normal limits or reassuring during your presentation, instead of, saying all the numbers and values. So I can give you an example, so let's go back to this list here. So I'm in the morning rounds, right? This is Mr. John Doe. He's a 45-year-old male whose status post right thyroid lobectomy on the 25th of January because of papillary thyroid cancer. His hospital day 5. Overnight, his pain is well controlled. He's not having any symptoms or signs of a cervical hematoma. In terms of his vitals are within normal limits and reassuring. Actually, no, if I look at the specific, he's been febrile overnight with a Tmax of 39. He's been a little tachycardic in the 100s. His blood pressure has been within normal limits. He's saturating well on room air. He had good intake orally yesterday. He's making appropriate urine based on his weight. He's having bowel function. His labs are significant for, potassium was, let's say, 3.4. And his white count, his hemoglobin is within normal limits. And, I'm already done with S and O. Assessment and plan. Assessment. This patient is febrile, and the plan would be I would like to work up this patient's, fever, maybe get a repeat CBC, maybe get a urinalysis, maybe do a chest X-ray to look for pneumonia, that would be my plan. So that's how a SOAP presentation would go for Mr. John Doe here. But again, just kind of modify it to the team's dynamics and to the patient. And if you have trouble coming up with plan, because that's the thing that most people have trouble with, always ask the question, what can we do for this patient to get them out of the hospital? And yes, it sounds terrible, right? Because they're here to get better and all that. But the ultimate goal is to get the patient out of the hospital. And yes, in the pursuit of getting them out of the hospital, we're going to treat them. We're going to, treat their fever. We're going to treat their electrolytes. We're going to make sure that they're stable at discharge. So ask yourself, what can we do to get this patient out of the hospital? And if you can't think of anything, then the answer is the patient is ready to leave the hospital. Okay. So if you have trouble coming up with a plan, just ask yourself this question: what can I do? What does this patient need to discharge? Okay. And so this is how SOAP presentations go, and you will get better at them as you go along. All right. I mean, at the start of my residency year, I was pretty terrible at them. So just comes with practice. Okay. And to practice, you just have to repeat a lot. And to repeat a lot, you have to do it every single day. All right. This is what I said. About 7, 8 a.m. after rounding on the patients, you will go to the OR. Now, if you in the OR, right? If you are performing a procedure, if you're performing a surgery, you should know the patient and should know the procedure. Okay. So if you're going to an OR for a particular type of surgery, then if you don't know the things that we're going to talk about in the next slide, then you should not go to that OR, because the attending will ask you questions. And if you don't know the answer to them, then it'll show that you're not well prepared. And I'll give you the example of a thyroidectomy for PTC. So things to know: you should know the name of the patient. It's very, very inhumane, I would say, not to know the name of the patient you're cutting open. Okay, know the age of the patient, know their past surgical history. And yes, you should know this, before you enter the operating room, and events leading up to the diagnosis of that. For instance, in this case, the PTC. This patient is having a thyroidectomy. You should know their thyroid function tests preoperatively. You should know the results of their ultrasound, their CT scans, their FNA results, because all of that is important in the workup of PTC, and that led to them having the surgery. So you should know that. You should know what kind of operation are we doing today. Are we doing a total thyroidectomy? Are we doing a thyroid lobectomy? What approach are we using? You certainly should know the anatomy, what structures we're going through and all that. You should be able to identify structures as we go along. And then, in the workup of PTC or thyroid nodules, you should know the Bethesda scoring system. So, of course, this is just applicable to this particular example, but know the workup that has been done to get this patient to the OR and the results of that workup. And then just know basic knowledge about the pathology that's going on. So know the type of thyroid cancers and their managements. Of course, know the neck anatomy and the basic steps to do the thyroidectomy. Okay, so we've talked about all of this before, but this is in the context of a particular example, so you guys know what it looks like, what it feels like to be a med student who's going into the OR. Now, if you're on a surgical service that's busy, that you might be leaving a little late in the night time, and so you don't have time to look this up in the morning, okay? Because you've been getting the numbers, you've been pre-rounding, you've been writing notes earlier, so you have to do this the night before the operation. Write this down on a piece of paper and bring that paper to the OR with you, and that'll really impress a lot of people. Okay. All right. So what to do inside the operating room? So this is, again, a combination of everything that we've talked about. Introduce yourself and your role to everyone in the room. Okay. My name is XYZ. I'm a final year med student coming on the service. And then usually if you're on a particular service, then you will be seeing the same kind of people every single day. So they'll get to know you and you'll get to know them. When you're in the operating room, as I said, it's all hands on deck. So do not stand idle. Just help with the patient positioning. Drop the Foley and help, as I said, help position the patient. If the NG tube needs to be dropped, and do that. Site marking, site marking is done before the patient gets to the operating room. Just make sure it's done. Help put the compression stockings on, which are prophylactic for DVTs. You will find something to do in the OR. So don't just stand in the corner and not do anything, okay? It'll make you look bad. Ask the nursing staff, ask the OR staff, how can you help them best, okay? Because while yes, it is all hands on deck, and you want to be of the most assistance to everybody, you don't want to overstep. You don't want to be in the way of someone doing their job effectively. So just also ask what their expectations of you are. As a med student, pull up the imaging on the OR computer. So the patient is having an orthopedic procedure. Pull pull up the films that are necessary to to review before the operation, and just before scrubbing in, just discuss with the attending or the senior person that's with you, what are we, just discuss with them what you're doing, and don't ask them, okay, what are we doing for this patient today? No, you tell them, okay, so it looks like we're doing a cholecystectomy on this patient because of a history of biliary colic. Are we doing it laparoscopically? Are we doing it robotically? What approach are we using? Where are we going to make the incisions? I saw the images and it looked like this patient's gallbladder was pretty inflamed. Are we expecting, conversion to possible open procedure? And that'll tell the attending, and do this more with attendings as well, that you are prepared. Okay. So yes, you're learning, but you're also prepared, and you're showcasing, you're showing off, and that'll make them remember you in a much better way. Always be eager to scrub in first. During the operation, ask questions, ask thoughtful questions. Don't ask questions for the sake of asking questions, because you will be called out for that. And, read the room really. So if this is, if a complication has happened during the surgery, if it's a tenuous procedure, if it's a tense environment, and don't be like, oh, is that the renal artery? Like, no one cares. Okay, just zip it and just be quiet for some time and let things settle out, and then ask your questions, because then you're just going to be the annoying person in the room. Okay. And however bad it sounds, surgery is a lot of monkey see, monkey do, right? So you observe and you just replicate. You see it enough time, you're able to do it yourself. As long as you're learning the basics, you're learning the theoretical part of aspects of the procedure as well in the background. So that's what you do in the OR to stand out. And after the OR, just help transfer the patient to PACU, which is the post-anesthesia care unit, offered to hand off to the PACU staff. That's basically telling the PACU staff who will be taking over the care of the patient after the OR what you did, what is expected. Will the patient go to the floor? Will the patient go home? Will the patient go to the ICU, et cetera, et cetera. Okay. Again, so some of the other things that you can do while on the rotation is always offer to help. We talked about that. Offer to take weekend calls, offer to take 24-hour calls. Doesn't have to be every weekend, doesn't have to be every other day. Just do it once or twice, and they'll first give you an idea of what it looks like to be on call, work the weekends, and also showcase that you're interested in learning. And then a lot of the programs have designated surgical education time for its residents, so always be there. There's nothing is more important as a med student than you going to those surgical education, whether it's lectures, whether it's simulation sessions, and then presentation. Always offer to present a topic. Just ask your attending if you can pick a topic, and you can do a quick presentation on it, 5-10 minutes, and that'll show them your academic skills as well. So those are some of the other stuff that you can do while on a surgical rotation. Next up is how to develop a lasting relationship with your attending. I think that's really important. Discuss. Okay. So now the reason this is important is because you're going to have them write you a letter of recommendation, and also possibly, put in a good word for you if you're applying to that program. So meet with the attending prior to the rotation and discuss expectations. All right. So sit down with them and discuss what is expected of you as a medical student, coming on their specific service, coming on that specific specialty. Now, once you've done that, apply what they've told you in addition to all the other stuff that we've talked about in the next 2 weeks. Midway through your 1-month rotation, you meet with the attending again, and then you discuss your progress in the past 2 weeks and ask on feedback and how you can improve further. And again, this tells you that you are asking for feedback. Your goal is continuous improvement. Okay. So once you do that, again, this midway meeting, this mid-rotation meeting is not something that you do in the hallway, in the OR while operating. This is something that you schedule a 10-15 minute meeting with the attending in their office or on coffee or whatever. And then you talk. It has to be a semi-formal talk. All right. Now, in terms of the letter of recommendation, it's kind of, what's the word here? It's debatable whether you should, ask for a letter during this mid-rotation meeting versus later. I am of the opinion that yes, you should plant the idea of a letter of recommendation during this mid-rotation meeting, and it sets you up to get the letter after. And the reason for that is, or the way to do that is, you sit down with the attending and you give them a little background. So, thank you for your feedback and appreciate it. I've been having a great time on your service. As you know, as an international medical student applying for residency in the US, your letter would go a long way. I would appreciate, you writing me a letter. And I also just wanted to ask what I can do in my remaining time here to get a good letter from you. While some people might say that, if you say this, that it makes it look like you are doing everything just to get a letter. And while that is true, it may sound bad, it might look bad to the attending. I personally don't think that is true. I personally think all the attendings that you rotated with are aware that you're there for a letter. Okay. And so it's not unreasonable to plan the idea of a letter during the mid-rotation meeting. And some of the times the attending will just tell you, probably at the beginning of the rotation, you're going to need a letter, right? All right, this is what you do. All right. So I personally think it's a good idea to ask for a letter midway, or not ask for it, just be more subtle, but yet obvious, you know what I mean? And I'll leave this up to you guys, to do it appropriately. And if you even decide not to do it, based on advice for some other people, apply the feedback that you got during this mid-rotation meeting during the next 2 weeks, or for the next 2 weeks, and then meet at the end of the rotation. And this is when you be like, all right, I've been doing everything you've been telling me. You're nice, of course. It's a formal meeting again, scheduled, and you discuss the letter of recommendation, and you have them write it for you. And then after you're done with the rotation, you send them a post-rotation email. I'll talk about that in the next slide. And then I put research on here because one of the other ways to develop lasting relationship with your attending on the rotation is if you offer to do research. And this has to be done much earlier on in the rotation. I did some data collection with one of my attendings on one of my surgical oncology rotations, and we developed a pretty good relationship. I mean, I emailed him long after I left the institute. So do that as well, and you get, one, a good relationship with the attending, and two, possibly a publication as well. So that is why I have the research thing here. All right, post-rotation email is very important. When you leave the institute, you're going to send an email that thanks the attending for their, for teaching you all that they've taught you and all the learning experience that you've gotten. And this is one of the emails that I had sent out after my cardiac surgery rotation. I'm just going to read it out for you. This is what the title of the email would be looking like. And then introduce yourself. In the heading, in the first line of the email, introduce yourself and tell them that you were there for this month. And the reason for that, we'll come back to it a little bit later, but mention that you were there for, let's say, March 2023, okay? And then you would thank them for, having them on their service. You're going to talk about how, these past 4 weeks have been remarkable. And, you've had the chance to, learn about preoperative, postoperative, intraoperative management of various cardiac surgeries. I told him, I didn't include it in this email, but you can also pick out a single very interesting case that you did, and then you can talk about that case in this email and say, okay, this was a very enriching, very enlightening experience, and I'm going to remember it forever. Okay. And then at the very end of the email, you're going to thank them and remind them that, yes, you agreed to write me a letter of recommendation, so you better do it. Okay. Obviously, you don't say it like that, but so you might word it like, I'm very grateful to you for agreeing to write me a letter of recommendation, who greatly aid me in my upcoming residency application. And then, of course, you attach your updated CV to this post-rotation email. Feel free to do it however you like, but have these important points in that email that you send out to the attending after you've left. All right. Now, why is this email important? Yes, you're thanking them. All right. You can just do that in person. The reason is, the way that the letters of recommendation work for ERAS is you send the attending a request through ERAS to upload a letter from their end, okay? And this might be months after you rotated with them, right? So this was in March. I applied in September, okay? And the letters could be, and the earliest the letters could be uploaded was June. So it was like a good 4 months before I ended this rotation. So when it comes the time to upload that letter, you can just reply to this email, and this will remind the attending that, oh, this was Safwan who rotated with me in March 2023, so they'll remember the time that I was there. And then if you have included some things that were very unique, very personal between you and your attending, then they'll for sure remember that it was you, and they remember that this is the person that I had agreed to write a good letter for. Maybe they've already written it; they just have to upload it, right? And so I think this serves as a very good anchor to your attending, and develops a good relationship with them. lasting, and also, helps you get that letter on ERAS. And I can tell you this works. Okay. If I had not written this email, and if I had not replied to this when the time to upload the letter came, some of my letters would not have been uploaded. Okay. So I think it's a really good idea. Now, the next thing that you can attach to this email is totally optional. I just tried it for one rotation. I think I just got a little lazy. I didn't do it for the rest of them, but attach something called a learning portfolio. And this is totally optional. This is the list of things that you've learned during the rotation. I've never seen anyone do it, but I think it's so unique. And if you do it, it makes you stand out in such a good way that, everyone reviews objectives before a rotation, right? Everyone reviews the list of things that they have to do before a rotation. So, they can check all the boxes, but no one organizes and summarizes the things that they've learned in a precise, concise manner and sends it back to the person that taught it to them, right? So I think that's something that might make you stand out quite a lot. So this was like all the type of cardiac surgeries that I had been exposed to: cabbages, mitral valves, tricuspids, TVARs, aortic stuff. And then to talk about all the aspects of patient management, intra, pre, and post-operative, and specific things that I learned. So, I didn't know how to interpret like an echo. So I learned how to do that on this rotation, CT scans. And so you can include that in a concise way. It doesn't have to be long. Okay. And best to do it in a listed manner. And this will really tell the attending that, you weren't just there to, show off. You've actually learned something. And I think this would go a long way for a good letter as well. So again, it's totally optional. It takes a little bit of time to do, but you can set yourself up to do it if as you're going through the rotation, you log all the cases that you've been doing, and you note down any important learning points that you've achieved. So making this document at the end would be a lot easier. Now, while you're on a rotation, you can't just, you're not just doing the rotation, you're doing a bunch of other stuff, which I think is really important. And this is just to make the best of your time on that rotation. So if you haven't done your step 2, you can study for your step 2 on the rotation. It's going to be difficult, but you have to do it. So if you're applying for September 2025 cycle, your step 2 should be done by, I think, July. I think it should be done by July. Yes, there's a certain date which they tell you it's, you can go as far as that, but I just don't think it's safe. Of course, if your situation is such that you will need to do it that late, then that's completely fine. But study for your step 2 during the rotation. If you haven't done the SMLE and the OET, these are requirements for a U.S. residency application. You can do these exams in the U.S. Yes, you can do the SMLE in the U.S. You can start working on your ERAS application while on the rotation, your personal statement, your experiences section, and then you can do some research as well. We talked about research earlier. You can continue to do the research that you've been working on, and this will make sure that your rotation is not just it's not just a clinical rotation where you get a letter out of it. You're doing all these other things in parallel as well, which are required or at the very least important for your ERAS application. And just don't leave them to the end. So I did my OET while on a rotation. I wasn't able to find a prometric center that offers SMLE in the area that I was rotating in, but there are in the US. I already done my step 2 before I started my rotation. I started working on my PS, my ERAS application, while on some of my rotations. So so keep doing that if you find, and it's going to be difficult. I'll tell you that because surgical rotations, long hours. Okay, especially if you want to impress people, you're going to be there for a long time. First one to come in, last one to leave, right? So it's going to be difficult, but nevertheless important. So if you can squeeze some of this stuff in, that would be great. That's about it. I would like to end this presentation by a quote from one of the Mayo brothers. The best interest of the patient is the only interest to be considered. And the reason I add this here is because you're there to learn. You're there to show off. But at the end of the day, the priority that is the highest priority is the interest of the patient, or good patient care. And I'll give you an example. If you're on rounds in the morning and you forgot to look up, let's say the hemoglobin of the patient, or you don't remember it, you forgot to write it down, and the attending asked you, what's the hemoglobin of the patient? And you immediately reply, oh, it was normal. It was like 12. And you're not sure of that, but it showed the attending that you prepared. It showed the attending that you've looked at the medical record, and it may impress them, right? But is Is it truthful? Is it actually true? No, it's not. Yes, the attending was impressed. Yes, he will probably, you know, use this as a point in your letter that this person knows their numbers, but it's not true. And the patient's actual hemoglobin was much lower, and something had to be done about that. And so you compromise patient care for the sake of impressing someone else or getting a good letter or learning. Okay, so never ever ever compromise patient care. If you're not sure of something, just say that you don't know it. You're not sure, and you will look it up and get back to the attending or the consultant or the senior resident, because the only interest to be considered is the patient's interest, right? And in the pursuit of good patient care, all the other things are going to follow seamlessly. So with that, I finished my presentation. Thank you for your patience and listening. I welcome questions now. Did you do a sub internship? If so, how's your experience? How did you secure and what prepares you for hands-on experience in the new healthcare system? I think I talked about all that. What is the difference between a sub-I and an elective? So in terms of US clinical experiences, we have elective, sub-internships, and acting internships. Sub-internships and acting internships are pretty much the same. An intern in the US is a first-year resident. So I'm actually an intern in the US. So if you go to the US, don't tell anyone you're an intern. Just tell them you're a medical student or a final year medical student. In essence, sub-I or AI are more hands-on than an elective, but I personally didn't find a difference between them, except for the fact that I was able to write on my application that I did a sub-I when I did a sub-I, and I think it stands out more. But if you find an elective, that's just as good. There's no difference in experience in terms of hands-on experience, in terms of exposure. So we'll be doing all the stuff in either elective or sub-I. It's just the title that's different, that might add to your application later on. But in terms of experience, it's not different. What is different, however, is an observership. An observership in a surgical specialty, I think, is pretty useless, unless you can't find anything else, because you won't be allowed to touch patients, you will not be allowed to scrub, and you will not be allowed to operate. So might as well just do a medicine rotation, right? We talked about that. Hospital name matter. Yeah, I guess it matters to an to an extent, especially for surgical rotations. I guess it's best if you don't go to a private practice, like a private hernia practice or a private bariatric surgery practice and do rotations there, unless that's the only thing that you find. But as long as it's the specialty of interest, I think that's good enough. But of course, big names do matter. So I have had, during my residency interviews, people be impressed by the fact that I did a rotation at the Cleveland Clinic or the Mayo Clinic or et cetera, University of et cetera. So I would say the name does matter to a certain extent, but if you can't find anything there, then, and there's no alternative than to go to a little bit of a smaller place with not that much of a name, then that's very reasonable. Because as I said, it has to be a letter from the US. I talked about observerships. If not, are observerships beneficial? I would say not as much. If you can't find anything, sure, go for it. But I personally don't think in a surgical specialty observerships are nearly as good as sub-Is or electives, because you will not be able to do anything. Should I save up later for electives? Yes. Priorities to build connections for later. I don't understand that. I mean, priorities to build connections for later. I'm not sure what later means. Yes, you are building connections throughout this experience, but you also have to get a letter out of it. You have to get experience that you're going to be able to write on your residency application. So, and you build connections through this as well, So if you have time or, the money for observerships, then go for it. But I don't think that an intern does. But if you can find observerships after graduation, because you cannot do electives or sub-Is after graduation because you're not considered a medical student, then you can go for those observerships. How did you learn anatomy? What is your recommended strategy? Good question. Netter's anatomy, I think, is excellent. Teach Me Anatomy, is also very good. Review the pictures and be focused to the specialty you're rotating in. Okay, you don't have to know everything. Just if you're doing bariatric surgery, know the stomach, know the intestines, know the ligament trites, know the different landmarks. You don't have to know everything, but you have to know all of what all of the things. You have to know all the important anatomy of the specialty you're rotating in, period. Is it must to have step one exam before applying? Yes. Get an elective for the most part. I've never seen an elective without step one. Is it important to be graduated from med school for electives? In fact, you should not be graduated from med school for electives. So the graduation that you guys have after fifth year, that's a fake graduation. The true graduation is after internship. So the 12-month of internship, while you're called an intern and called a doctor in Saudi, you're not. You're still a med student. You're still considered a med student in the US because you don't have your degree. After graduation, you cannot do electives. You cannot do sub-internships because you're not a med student, and you cannot be protected by the hospital's, I guess it's malpractice insurance or something that is available for med students, but it's not for graduates. Yeah. You can do observerships, I think, as graduates, but not electives. As for OB/GYN rotation, how long is it? Also, any other info that you have about this rotation? I'm not sure what that question means. A rotation is something that you apply for. It's usually 4 weeks long. Yeah, that's all about I can tell you. So a rotation is you apply for an elective. So when I say rotation, I mean elective, sub-I or acting internship. And these are 4 months experiences that you go and do at a hospital in the US. At least this is relevant for this talk here. You go do those 4 weeks, in the US, and you get experience, you get the letter out of it. If you're talking about, the OB/GYN requirement from Alfaisal, that is a completely different thing. But if you're looking to do an OB/GYN residency, then it would be better in the US. It would be better to do electives. It would be better to utilize your OB/GYN months in the US rather than doing it in Saudi. For non-Arabic speakers, the language barrier in the fourth year makes it challenging to practice H&P. That's an excellent question. I'm not an Arabic speaker, and it'll just come with time. It's, as I said earlier, you're going to be talking to real patients. And for non-Arabic speakers, this might be like one of the few times you've had a chance to talk to a real patient face to face without an interpreter in between. So I guess, you could practice with your friends, you can practice by yourself, and it will come with time. And that is a very valid question. It's hard to learn in clinics or during rounds due to most communication happening in Arabic. I feel information that's provided during these activities is essential to do well in electives. Do you have any advice about that? Also, a very good question. I mean, I went through it and I did completely fine without the information that was provided during rounds in clinics. I think going back to the resources helps a lot. Up to date, Netters, whatever pathophysiology book that you're using, up to date, I think is excellent. And after you've interacted with a patient a couple of times, it'll just come very easily after that. And don't feel that you missed out on information that was provided during rounds and clinics in the past, because it's not much different than things that you'll find on the education resources that I've talked about. So it's not going to be much different. And then you can always discuss with attendings and residents before you go into a patient's room as to what are their expectations from you for that patient interaction. Have you had days without good sleep and being in the OR next morning? How usually this could be managed to present before anyone else and be the last one to leave, especially in high volume institutions? How it is handled in such settings? That's a good question. Yes, many days that I went without having good sleep during the electives. I think power naps are really good if you get time to do them. Alarms, set your alarms, eat good. And it's going to be difficult to, be there before everyone else and leave the last. But it's also okay to, if someone tells you to leave, it's okay to leave at the end of the day. If it's getting very late, it's okay, and you just thank them and you get out of there. But I will also tell you that attendings have been impressed when I was a med student on their service that I stayed late. Okay. You make up for that on the weekends, and it's not completely undoable. I would say that, 6 hours of sleep, I think, is enough. At least for me, it is. And once you do it every day, you just, you might even wake up without an alarm. So you'll get used to it. And it is very common, not to be able to do much else. All the step 2 SMLE OET stuff that I talked about is very common not to be able to do that just because you don't have the time. And that's very reasonable, but it's also something that you should expect might happen on a rotation. Do they accept being asked for feedback, the residents and the people involved? Yes. At the end, could you kindly discuss the weightage of research in general for a US application? I am not a research person because, I had a few publications when I applied to residency, and it's not anything like what some of the people are doing right now at Alfaisal, which is excellent. But certainly research is very important, especially for surgical specialties. In fact, people opt to do research years before going into a general surgery residency. I think it's doable without as well, as long as your scores are good, as long as your experience is good, as long as your letters are good. But if you need to, take some years off after graduation to do research, I think that's completely reasonable as well, just to build up your portfolio and improve your application. For some of the specialties, of course, like neurosurgery and orthopedics, research is, it's very important. You can't apply with a couple of publications as an international medical graduate. So in those subspecialties, I think is more important than, let's say, maybe general surgery. And there are, stats available online on NRMP that can talk to you a little bit about, importance of research. Do you think it's a good idea to do a gen surg rotation here in Saudi before going for electives? I think that's a very good idea as well. If you get a chance, if you have the time to do a gen surg rotation here in Saudi, I think that'll really set you up for doing good in during the electives, as long as you have left enough months to do rotations in electives in the US, because enough months mean enough letters. I guess one of the things that I didn't bring up earlier was, if you're doing a month's rotation, and you're kind of assigned to a certain attending or consultant, you can still get more letters during that rotation by spending some times with other attendings and consultants and operating with them on days that your assigned attending is off or on vacation or has an administrative day or has maybe clinics, right? You can always offer to help operate or spend time with some of the other attendings. So for instance, and some of the institutions actually do that. So one of the rotations that I did, I had 2 weeks with a certain attending and 2 weeks with another attending. And then I spent more time with a third attending. So I got 3 letters from that rotation. But, it can be a little difficult, but you really have to kind of just gauge the situation. It's very, very individualized, right? It really depends on the situation that you're in. So you can certainly get more than 1 letter out of a rotation. You need 3 letters you need at least, for a general surgery residency, at least, this is what I'm aware of, you need 3 letters to apply. So, and you don't need the dean's letter or whatever. Oh, sorry, I don't know the clerkship. No, I don't know what it's called. The medicine people use it. But you should do 2 to 3 months. You should aim to have 4 letters, for surgical letters, for applying to a general surgery residency, for instance. And you can use all of some place very, very probably I can count them on my fingers is the number of places that require 4 letters for residency application. But, if you can do 2 to 3 months, you can probably get 4 to 5 letters out of them. So that's what I would say, 2 to 3 months.
I think that's pretty much it for all questions. I don't know
All
if
right, cool.
Thank you so much, Dr. Safan. That was truly insightful, truly enlightening. Thank you so much for sharing your time and knowledge with our attendees. I'm pretty sure that all of them find it truly beneficial, including me. It taught me so much. Inshallah, we'll look forward to seeing you soon, maybe in US. And we wish you the best
Yeah,
in your
come
residency.
here. Yeah. Thank
Inshallah.
you. Wish to see some of you on, if you plan to do gen surg rotations, always feel free to reach out, and we can talk about expectations that are specific to this institute for sure. Yeah. All
Thank you
right.
so
Thank
much.
you, everyone. Have a good day. Bye.
Thank you. Bye bye.